So this is about a case being a post-transplant case being complicated by varicella zoster infection. So this is about a 35-year-old male with a native kidney disease being biopsy-proven IgA nephropathy in the 2015, and was started on dialysis with the dialysis vintage of 7 months on thrice-weekly hemodialysis. No history of any blood transfusions or any emergency admissions in between. And he underwent an ABO-compatible live-related renal transplant surgery with his mother being the donor in January 2020. So CDC was done, CDC cross-match was negative, and with no induction agent, only pulse methylprednisolone was given with warm ischemia of 4 minutes and cold ischemia of 97 minutes, and he was started on tacrolimus, MMF, and prednisolone. So this is a preoperative investigations, which is nothing significant except for anemia with a hemoglobin of 8.8. Thus, all the investigations were within normal limits. So in the immediate post-op period, it was actually stable with the immediate post-op renal artery Doppler within normal limits, and the tacrolimus dose was titrated to 5 milligram, 2.5 mg BD on post-operative day 4, and the TAC level was 1.4, and the creatinine levels were basically around 2.6 milligram per deciliter. But on the 8th post-operative day, he developed vesicles over the chest and the upper back, and the creatinine value was around 2 at that particular point of time. So he was started on injection acyclovir, renal dose modified. So we basically went ahead with 10 mg per kg per dose, but was given on a OD dosage, and the MMF was withheld. So as we can see from the tabular column, 29th of January, he had basically creatinine value of 2, and hence at that particular point of time, he was diagnosed with varicella and started on acyclovir. And on post-operative day 10, that is 6 days after the initial appearance of the vesicles, he had features of lower respiratory infection, and the CT chest was taken, which showed evidence of right lower lobe consolidation, and the antibiotics was uptitrated to injection meropenem. And 2 days later, basically, we found out that no new lesions were appearing. So the injection acyclovir was basically down titrated to oral val acyclovir. And on post-operative day 13, he had elevated liver enzymes with moderate thrombocytopenia, but with a normal coagulation profile. So even the OTPT went up to around the range of 2,500 and 2,200. And the platelet count was dropped even to around 31,000. However, since the patient became better with the antivirals, and on the post-operative day 15, that is 11 days after the initial vesicle had appeared, MMF was restarted in the half dose. And on post-operative day 19, as the lesions subsided completely and the lung signs became better, liver enzymes also showed improvement along with the platelet count. The valacyclovir also was basically stopped. And on 20th day, the patient was discharged on full dose medications and with a normal renal function. So hereby actually showing a case where it has been complicated by post-transplant varicella with right lower lobe consolidation and hepatitis and with thrombocytopenia. So how can we prevent the varicella infection? What are the strategies available? So basically in the pre-transplant phase, we basically have the antiviral agents, which are basically of no use. The vaccination becomes more important over here. Especially we do have the varicella vaccine. There are 2 live attenuated vaccines, basically Varivax and Varilix. So both are basically live attenuated, and it can be used in the pre-transplant phase. And we also have zoster vaccine, Zostavax and Shingrix. So Zostavax is a live attenuated one, and Shingrix is a recombinant vaccine. So in the pre-transplant phase, prevention is basically hinged upon the vaccines. So as already, the vaccine has multiple benefits. So it prevents varicella of any severity by 80%. So previously we used to follow the single dose strategy, but currently the schedule is 2-dose strategy, which basically covers 93% of any varicella infection. And it also, the 2-dose strategy, it reduces the risk of severe disease by 99%. It reduces the number of breakthrough varicella cases, reduces the risk of transmission, and also reduces risk of herpes zoster in children. So the types, both are live attenuated. One is a single antigen vaccine, Varilix and Varivax, which basically contains 1,350 plaque-forming units of OCA strain, and the MMRV vaccine, which is the varicella vaccine given along with the MMR, which basically contains a higher strain of plaque-forming units of varicella zoster. So that is 9,772. So often the choice in the current guidelines is single antigen vaccine. The dose is 0.5 ml sub-Q or IM. Contraindications include anaphylaxis basically to vaccine components, including neomycin or gelatin, pregnancy or those planning for pregnancy, severe immunosuppression, and those on high dose of glucocorticoid therapy, which is basically a 20 milligram of prednisolone for more than 2 weeks, or those having untreated active tuberculosis. So these are the 3 basic vaccines that we have in the world: the varicella, Varilrix, Varivax, and the combination with MMR. So the strategy is often 2-dose strategy, which gives a mean effectiveness of 92 to 93%. So 2-dose strategy, by accepting those, it gives more seroconversion, more increased antibody titers, and a long-lasting immunity. And in the adult, basically the 2 doses are being taken within a gap of 4 to 6 weeks or 8 weeks time. So regarding the vaccine, special points has to be kept in mind. It is very susceptible. That varicella vaccine virus is susceptible to the antivirals acyclovir, valacyclovir, and famciclovir. The salicylate should be avoided for at least 6 weeks after the vaccine for the risk of Ray's syndrome. And in a person who has received blood products or immunoglobulins, the vaccine should be delayed. So it is said that varicella immunoglobulin, if he has received it, the vaccine should be delayed by 5 months. If it is IVIG, which is the patient has received, the vaccine should be delayed by 8 months. Packed red cells, the vaccine should be delayed by 6 months. And plasma, the vaccine should be delayed by 7 months. So this is the IP guidelines where we have the varicella vaccine denoted by VAR and the zoster vaccines, recombinant, Shingrix denoted by RSV, and the live vaccine, ZVL, denoting Zostavax. And even in the schedule, it is actually seen that the live vaccines are basically contraindicated in the severe immunocompromised stage, that is in the post-transplant phase. So if we want basically to cover up the varicella, it has to be given pre-transplant. So in the pre-transplant setting, even the vaccine, the live attenuated vaccine, can be given as early as 6 months of age. Normally, it is said that the vaccine should be given after 12 months, but in infants who are awaiting transplant, it can be given as early as 6 months. And being a live attenuated vaccine, it is contraindicated in the post-transplant state and in severely immunocompromised states. And the IDSI guideline, it actually recommends a waiting time of at minimum 4 weeks between the second dose of vaccine and the transplant. And the 2 doses must be taken, if at all feasible, with a minimum interval of 4 weeks in between the 2 doses. And the varicella antibodies have to be checked after 4 weeks after the second dose. And if there is no seroconversion even after 2 doses, additional dose can be taken if time permits, or you have to go for post-exposure prophylaxis if the exposure happens. And if suppose the transplant is urgently indicated within the 4 weeks of vaccine being taken, we have to give the patient peri or post-transplant prophylaxis with antivirals, IV acyclovir or oral valacyclovir or famciclovir. And in a patient who has been subjected to post-transplant varicella vaccine, the risk of disseminated varicella usually exists. So this is about a special article which came in the American Journal, which details about the management of the varicella zoster virus in solid organ transplants. Now, regarding the adverse events with the vaccine, it may be associated with injection site reactions, rashes. The one point to be noted with the rash is that around 1 to 3% can have localized rashes, that is around 2 to 5 at the injection site, but 3 to 5% can have generalized varicella-like rash within 1 month. The important thing is that those with generalized rash, the physical contact should be avoided till all the rashes have subsided. Then the patients also can have fever and febrile seizures. With finally, dissemination of the vaccine virus can happen with complications of meningitis or encephalitis in a rare situation. So this is about a case report which came in AJT, which basically shows the chances of disseminated vaccine-induced varicella in a kidney transplant recipient. Now, regarding the antiviral therapies after transplant, it basically depends upon whether the patient is on a CMV prevention strategy. For those who are already on prophylaxis for CMV, no additional prophylaxis because it covers varicella. But who are basically not on any antivirals for CMV, the antivirals acyclovir should be given for first 3 to 6 months, 200 milligram 3 to 5 times a day. And if there are episodes of immunosuppression intensification, prophylaxis can be extended for additional 1 to 3 months. And in the post-transplant scenario, basically the post-exposure prophylaxis basically rests upon using the varicella immunoglobulin or IVIG with or without antiviral therapy. And even after instituting both the therapies, the patient should be monitored even after the therapy is instituted. So Varicig is a purified human varicella immunoglobulin, and it should be given as soon as possible and can be given up to 10 days following exposure. And the protection is expected to be there for around 3 weeks' time. And the antiviral agents, they are used as an adjunct to Varicig or for those who have not received Varicella even after within 10 days of exposure. And the preferred is oral valacyclovir 1 gram 3 times a day for around 3 weeks time. So this is about the post-exposure prophylaxis in varicella immunoglobulin or a basic IVIG and antiviral prophylaxis with acyclovir, which can be combined or may be given alone in case. And the treatment, basically, it hinges on the antiviral therapy, whether it is basically acute varicella in the IP phase, which is a severe infection, we prefer IV acyclovir, and basically down titrated to oral agents once there are no new lesions or the lesions gets crusted. So the dose is around 30 milligram per kg in a total day dose or 10 mg per kg per dose, separated 8-hourly, and it has to be adjusted for the basic renal function. And finally, complications of varicella infections basically have skin and soft tissue infections, the dangerous neurological complications in the form of encephalitis, which can either manifest as acute cerebellar ataxia in children or a diffuse encephalitis in adult. That is usually seen towards the first week. And pneumonia, which is a major cause of morbidity and mortality in especially varicella in adult, develops around 1 to 6 days after the rashes appear. Risk factors including those people who smoke, males, pregnancy and immunosuppression, and hepatitis, which does sometimes have a frequent fatal course, with rash can either precede or appear coincident or follow after hepatitis, and hemorrhagic varicella and purpura fulminans, which is usually seen secondary to varicella infection induced proteinase deficiency, and finally it can also lead on to retinal necrosis. So this is one Indian study which basically showed the distribution of the infection patterns in post-transplant phase, which was done during the immediate peri-COVID time. So the bacterial infections were the most common in 55%, followed by viral. Among the viral, it was basically COVID-19, which was more, followed by BK virus, and less commonly varicella. Now, this is one case of varicella zoster infection in kidney transplant recipients reported from Somalia. Then this is about one of the variant of varicella, that is verrucous varicella, with the rashes usually commonly seen in HIV patients. Sometimes it has been reported even in patients who are severely immunocompromised. And the case of acute retinal necrosis in renal transplant recipient, especially diagnosed with the anterior chamber paracentesis for PCR for herpes virus. So commonly there is progressive and bilateral visual loss. And finally, this is basically called as a HIN study, which is herpes virus infections in kidney transplant patients, observational cohort study where the herpes zoster vaccine, that is a recombinant herpes zoster vaccine, which is a glycoprotein E subunit vaccine, which was given pre-transplant, and the antibody formation post-transplant was actually being checked into to identify how many percentage of the patients had the adequate seroconversion. And finally, reminding what the vaccination in CKD, what are the vaccines that has to be taken in the CKD prior to transplant. It includes basically hepatitis B, pneumococcal vaccine, influenza, varicella, measles, inactivated poliovirus, and the DTs. Thank you.